Welcome back to the deep dive.
Great to be here.
Today we've got this stack of revision notes. Pretty detailed ones, actually, focusing on one specific condition.
Endometriosis.
Exactly.
Yeah.
And our mission, really, is to sift through these notes, pull out the absolute must-know bits, and turn it into a really high-yield session for your revision.
Yeah, think of it like a quick way to get up to speed covering the essentials.
Because it is such an important topic, isn't it?
Absolutely. It's common, incredibly impactful for those who have it, and these notes seem pretty comprehensive. They take us right from the definition through to management and complications.
Perfect. So we'll break it down section by section. Keep it friendly, keep it focused on what you need for revision. Ready to dive in with us?
Let's do it.
All right, let's start right at the beginning then. According to these notes, what exactly is endometriosis? What's the core definition we need?
Okay, so the notes define it as a chronic condition. Basically, tissue that's similar to the endometrium, the lining inside the uterus, starts growing outside the uterus.
Outside, like where typically?
Well, the common spots listed are the ovaries, the fallopian tubes, and other tissues lining the pelvis. And the key thing is this misplaced tissue causes problems, mainly pain and fertility issues.
Okay, so chronic tissue outside the uterus causing pain and fertility issues. Got it. What else characterizes it?
The notes really stress that it's chronic, and crucially, it's estrogen dependent.
Estrogen dependent.
Yeah, meaning its growth and activity are driven by estrogen, and it can pop up in various places. Pelvic ligaments, colon, bladder are mentioned specifically. Oh, and they also bring up adenomyosis.
Ah, yes. Is that different?
It is related, but different. Adenomyosis is when that endometrial-like tissue grows into the muscle wall of the uterus itself. The myometrium also causes pain, inflammation, adhesions, but it's within the uterine wall, not outside.
Right, important distinction. So endometriosis is outside, adenomyosis is inside the muscle wall, and the notes mention diagnosis often needs laparoscopy and histology.
That's what they say, yeah. Often need to actually look inside with a camera and take a sample to be sure.
Okay, let's circle back to that estrogen-dependent point. Why is that so important to grasp for revision?
Well, it explains a lot, really. It helps make sense of why symptoms often flare up around the menstrual cycle when estrogen is higher. And maybe more importantly for exams, it's the basis for many of the treatments, trying to manage hormone levels.
Makes sense. Targeting the fuel source, basically.
Exactly.
So we know what it is, where it hangs out. The big question then is, why? What do the notes say causes it? Do we know?
Well, here's the thing. The notes are pretty clear. The exact cause is unknown.
Still unknown.
Yeah.
For something so common.
Yep. Still a bit of a medical mystery. But they do list the main theories that are being investigated.
Okay, what are they?
So there's retrograde menstruation. That's the idea that some menstrual blood flows backwards up the tubes and into the pelvis, carrying endometrial cells with it.
Ah, okay. I've heard of that one.
Then there's genetic predisposition, seems to run in families sometimes. Immune system dysfunction is another theory. Maybe the body isn't clearing these cells properly, and general hormonal imbalances are also suggested.
Right. Retrograde flow, genetics, immune issues, hormones. It is fascinating that we don't have a definitive answer yet. So if you're revising, maybe just grouping those four main ideas, flow, genes, immune, hormones is the way to go.
Sounds like a good approach.
Okay. Moving from why it happens to who is more likely to get it, risk factors. The notes list quite a few, right? This sounds like high-yield stuff.
Definitely high yield for spotting potential cases. The common ones listed are having a family history.
Okay, the genetic link again.
Exactly. Starting periods early menarche. Having short menstrual cycles, they specify less than 27 days. Heavy or long periods, too.
So menstrual pattern seems key.
Very much so. Also, nulliparity, never having given birth. And then there's obstruction to vaginal outflow. The notes give examples like hydrocolpos, and they also list genital mutilation as a potential structural factor here.
Okay, presenting that neutrally as listed.
Yes. Then there are genetic factors again. White ethnicity is mentioned, having a low BMI, and also smoking.
Wow, okay, that's quite a mix. Family, periods, births, structural things, ethnicity, BMI, smoking, quite broad. To remember these, maybe group them, like cycle-related factors, family genetic links, structural issues, and then maybe demographic or lifestyle factors.
Yeah, breaking it down like that could definitely help cement it in your mind.
So how does this tissue, this ectopic tissue, actually cause the pain and fertility problems? What's the mechanism? the pathophysiology.
Right, so the notes explain that this tissue, even though it's outside the uterus, still responds to the monthly hormonal cycles, just like the normal endometrium.
Ah, so it tries to grow and shed each month.
Exactly, but because it's in the wrong place, like on the ovaries or lining the pelvis when it tries to shed, there's nowhere for the blood and tissue to go easily.
So it causes irritation.
More than irritation, it triggers an inflammatory response in the surrounding tissues. And over time, this chronic inflammation leads to scarring. Scarring, right?
And adhesions. These are like sticky bands of scar tissue that can kind of glue organs together, distort anatomy.
Ouch.
Yeah.
Right.
And it's this whole cycle, the hormonal response, the bleeding, the inflammation, the scarring, the adhesions that ultimately causes the chronic pain, can mess with how organs work and leads to the fertility problems.
Okay, so it's the body's reaction, the inflammation and scarring to this tissue being where it shouldn't be. That's what does the damage.
Precisely.
Now, pelvic pain, it can be caused by loads of things. So when thinking about endometriosis, what else needs to be on the differential diagnosis list? What else might look like it?
That's a crucial point. The differential is broad because the symptoms overlap with so many other conditions. The notes give a pretty comprehensive list we need to consider.
Let's hear it.
Okay, so you've got pelvic inflammatory disease, or PID, ovarian cysts, which can cause pain, irritable bowel syndrome, IBS that often causes pelvic or lower abdominal pain.
Right, the bowel connection. Yep. Interstitial cystitis, a bladder pain syndrome, adenomyosis, which we mentioned earlier, ectopic pregnancy, obviously an emergency, torsion of an ovarian cyst, another emergency.
Okay, lots of gynae and emergency stuff.
Then there's appendicitis, also urgent, primary dysmenorrhea, just painful periods without underlying endo, uterine fibroids, and urinary tract infections, UTIs.
Wow, that is quite a list. PID, cysts, IBS, bladder issues, adeno, ectopic, torsion, appendix, simple period pain, fibroids, UTI. How can you possibly keep all those straight for revision?
Grouping is probably the best bet, you could think. Gynae causes PID, cysts, adeno, ectopic, torsion, primary dysmenorrhea, fibroids. Then GI causes IBS, appendicitis, and urinary causes interstitial cystitis, UTI.
That helps. Breaking it down by system makes it less daunting. Okay, let's talk numbers. How common is this? The notes seem UK focused here.
They do. They state it's one of the most common gynecological disorders for women of reproductive age. The prevalence is estimated at about 10%.
1 in 10, wow.
Yeah, it's significant. And perhaps the most striking number is the average time to diagnosis. The notes say it's 7.5 years.
7.5 years.
On average, yeah. Usually diagnosed via laparoscopy. And it links heavily to infertility, affecting maybe 30 to 50% of women struggling with fertility.
That 7.5-year delay is staggering. You can see how the varied symptoms and diagnostic challenges we're talking about feed into that. Those are definitely numbers to remember. 10% prevalence, 7.5-year delay.
Absolutely.
So away from the numbers, what does it actually look like when a patient presents? What are the common symptoms they report? And what might you find on examination, according to these notes?
Okay, symptoms. Pelvic pain is the big one. Can be chronic, meaning ongoing, or cyclical, worse around periods. Location-wise, pelvic region, lower back, abdomen. Then there's dysmenorrhea, painful periods, often described as severe cramps.
Okay, painful periods.
Dyspareunia, painful intercourse, also very common. And heavy or irregular periods, menarche is mentioned later too. And as we said, infertility or subfertility, difficulty conceiving.
Those seem like the core ones.
They are, but the notes list others too, highlighting the variability. Things like bloating, tiredness or lethargy, constipation, low back pain again. Cyclical rectal bleeding if there's bowel involvement.
Bleeding from the back passage during periods.
Yes, potentially. Also diarrhea or hematuria blood in the urine if the bladder is affected. The note stress symptoms can get worse with age. Sometimes people are asymptomatic and non-gynae symptoms can be present.
So much variation. What about signs on examination? Anything specific to look for?
Often the exam is completely normal, the notes say. But potential findings include tenderness in the pelvic area, maybe palpable nodules. You might hear about chocolate cysts. Those are endometriomas on the ovaries, collections of old blood, or hemorrhagic nodules.
Okay.
Under the diagnosis section points, they specifically mention uterosacral ligament nodularity, feeling nodules on the ligaments behind the uterus, and a fixed retroverted uterus.
Fixed retroverted, meaning stuck backwards.
Yeah, suggesting adhesions are pulling it back and holding it there. Oh, and interestingly, depression is also listed as an associated finding, likely due to the chronic pain and impact on life.
Right. So the classic triad seems to be dysmenorrhea, dyspareunia, chronic pelvic pain. but crucial to remember that long tail of other symptoms and that exams can be normal. That variability, again, explaining the diagnostic delay. Maybe for revision, focus on the triad, then think where else could implants be to recall the other symptoms.
Good strategy.
So if we suspect it, based on all this, how do we investigate? What's the pathway in the notes?
Well, it usually starts with a pelvic exam, looking for those signs like tenderness or nodules. Then, often, a transvaginal ultrasound. The notes say this is particularly good for spotting ovarian endometriomas, those chocolate cysts.
But ultrasound isn't the final word.
Not usually for ruling it out, especially the subtle forms. The notes are clear. Laparoscopy is considered the gold standard for a definitive diagnosis of most types.
So keyhole surgery to look inside.
Exactly. Allows direct visualization, taking biopsies for confirmation, but it's invasive, carries small surgical risks, and interestingly, the notes point out that what the surgeon sees during laparoscopy doesn't always correlate well with how bad the patient's symptoms are.
So you could have lots of visible disease, but less pain, or vice versa.
Precisely. Other investigations mentioned include MRI said to be helpful for deep endometriosis affecting bowel, bladder, ureter. NICE guidelines apparently recommend it for that, but it needs specialist reading. CA-125 blood test is mentioned, but with limited diagnostic value on its own.
Okay.
And in an acute setting, sudden severe pain, you'd do standard things first. Bloods, urine test, swabs, pregnancy test to rule out emergencies.
Right. Rule out the differentials first in acute pain.
And a really key point for primary care. The notes state ultrasound has little role in primary care for ruling out endometriosis. If symptoms are significant, referral for definitive diagnosis, usually meaning laparoscopy and secondary care, is needed.
That's a vital takeaway. A normal ultrasound in GP doesn't exclude it if the story fits. And laparoscopy, while definitive, is surgery and doesn't always match symptoms. Complex.
Very.
So once it is diagnosed, how do we manage it? The notes seem to cover pain, surgery, fertility.
Yeah, management is very much tailored. Depends on the main problem, pain or fertility, and if they want to conceive. For pain, first line is often NSAIDs like ibuprofen and hormonal meds.
Hormonal meds targeting that estrogen dependence again.
Exactly. Things like the combined oral contraceptive pill or progestins. These also help control the disease progression, supposedly.
Okay, what about surgery?
Surgery is a big part.
Yeah.
Usually laparoscopic keyhole surgery to remove or destroy the visible implants, cut away adhesions, remove cysts like endometriomas. Hysterectomy, removing the uterus, possibly with ovaries and tubes, is mentioned as a last resort for severe cases where fertility isn't an issue anymore. Specific terms listed are excision, ovarian cystectomy, adhesiolysis.
Right, removal options
Yeah.
and fertility.
For fertility issues, assisted reproductive technologies, or ART, the notes mention controlled ovarian hyperstimulation using drugs like clomiphene, maybe is a first step in RT, then IVF is the next line if needed.
Okay. Any other management points?
Lots nuances. Treatment is tailored. Other medical options listed include medroxyprogesterone acetate, progestin, GnRH agonists. These basically switch off ovarian hormone production temporarily.
Like a temporary menopause.
Sort of, yeah. And the levonorgestrel IUS, the hormonal coil. Referral to gynae is needed for severe or persistent symptoms. Laparoscopic surgery, specifically to treat the disease, can improve pain more than just looking. Crucially, hormonal treatments that stop ovulation shouldn't be used if someone's trying to conceive right now.
Makes sense.
Laparoscopic surgery might improve natural fertility, especially in mild cases. IVF is for when other treatments fail or there are other infertility factors, and there are different treatment combos depending on symptoms and pregnancy plans.
So lots of options in tailoring. What about guidelines?
NICE guidelines from 2017 are referenced. They suggest starting pain relief with NSAID paracetamol. If that fails, hormonal treatments like the pill or progestogens. Refer if those fail, or fertility is the priority. Secondary care options include GnRH analogs and surgery, laparoscopic excision, or laser treatment.
Okay, so a clear stepwise approach.
Yeah.
Simple painkillers, then hormones, then referral for more advanced medical or surgical options, plus specific fertility pathways.
Yeah.
It's not one size fits all, is it?
Definitely not.
Thinking about revision, maybe categorize management, medical, painkillers, hormones like COC, progestins, GnRH, IUS, surgical, laparoscopy for excision ablation, hysterectomy, and RT, ovarian stimulation, IVF.
That covers the main pillars, yeah.
What about the long term? What's the prognosis like according to these notes?
It's described as complex and variable. That's the main theme. It's not clear if it always progresses, stays the same, or sometimes improves on its own.
Unpredictable then.
Pretty much. Hormonal treatment usually controls symptoms well for most people. but complex cases might need long-term support. An interesting point. Up to 30% of untreated women with infertility might see spontaneous regression.
Really? You can just go away sometimes.
Apparently, sometimes. But on the flip side, about 50% might see progression over 6-12 months. And recurrence after surgery is common. The notes quote, rates from 10% up to 50% within a year, and it increases over time.
So chronic, unpredictable course. Treatment helps manage, but it's often about control, not cure, and it can definitely come back. Reinforces that need for long-term support.
Exactly.
Okay, finally, complications. What potential problems can arise from having endometriosis?
Several significant ones are listed. Infertility is major manage. The inflammation and scarring can damage ovaries, tubes, affect implantation.
Right.
Adhesions and organ dysfunction, that scar tissue can distort things, make organs stick together, causing chronic pain and problems with bowel or bladder function.
Okay, physical damage.
And then there's the impact on quality of life listed as a complication itself. The chronic pain, fertility stress, emotional burden. It significantly affects well-being and mental health.
Hugely important.
Additional specific complications mentioned: an association with certain types of ovarian cancer, clear cell, low-grade serous, endometrioid subtypes. Important to stress, it's noted as an association, not direct cause, but it's in the list.
Understood.
Moderate to severe disease is linked to tubal damage, worsening infertility. Adhesion formation can happen because of the disease or as a result of surgery. And there's mention of an increased risk of inflammatory bowel disease.
That really underlines the wide-ranging impact. It's not just period pain. It's fertility, organ function, mental health, potential long-term associations. It affects the whole person.
Absolutely.
Okay, so we've really unpacked these notes, covered the definition, the mystery cause, risk factors, how it works, what else it could be, how common it is, how it presents, investigations, the whole management ladder, prognosis, and those serious complications.
Yeah, I think for revision, the key things to hold on to are that core definition, ectopic tissue, estrogen-driven, the main symptoms and risks. Knowing laparoscopy is the gold standard for diagnosis, but understanding the pathway and limitations, grasping the range of management, medical, surgical are key. And remembering it's chronic, variable, and can have a huge impact.
Hopefully walking through it like this has made it clearer for you listening, whether you're hitting the books for exams or just want to understand endometriosis better.
And thinking about it all, especially that huge diagnostic delay, 7.5 years, and the symptom variability, it does raise a big question, doesn't it? Given all that, what more could actually be done by healthcare systems, researchers, maybe public awareness campaigns to try and shorten that journey for women? How do we diagnose this quicker?
That's a really important thought to leave people with, a huge challenge. Well, thanks so much for breaking that down with us.
My pleasure.
And just a reminder, if you are prepping for the MSRA exam, do check out PassThemSRA.com and FreeMSRA.com for loads more resources. Thanks for joining us on The Deep Dive.